I don't want to risk having to also do chemo and radiation. So I wanted to be really in control as much as possible of a disease and a disorder I can't control at all.
Coming up today, making the choice to beat cancer before a diagnosis. This investigative reporter knows her genetic risk, so she did her research and found out the best option for her. We follow Kristin Crowley's medical journey from exams to surgery. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Well, she's an award-winning journalist, a wife, and a daughter. She's also a patient who faced a difficult choice. What do you do when you have a family history of breast cancer and carry the BRCA2 gene mutation? For women, it's a choice. Do you play the odds or take control of your health? For Kristin Crowley, the choice was clear. She recently underwent a double mastectomy, and we're going to explain what that all means here in just a moment. But first, we want to welcome Kristin to our studio. So great to have you.
Hey, it's great to be here.
Good to see you. Also joining us, breast surgical oncologist Dr. Jamie Wagner. Dr. Wagner is also the director of the breast program at the University of Kansas Cancer Center. How are you?
Good morning. How are you?
Good, very good. We also welcome nurse navigator Teresa Isabel. Thank you for being here.
Good morning.
Good morning. Kristin, I want to get started with you. Let's talk about your story, because when you first found out that you had the BRCA2 mutation, what went through your mind?
Yeah, so surprisingly, I think a lot of people would assume I was devastated and crushed, and I really wasn't. And I don't mean that to minimize anybody who does feel that way when they get this diagnosis, but for me it was answers. It was, I have a long family history of cancer, and now I know this is why, and now I can actually do something about it. So I kind of felt like I was given a superpower of being able to look into the future and know that I'm likely going to face this issue, and here are the steps now that I can take to thwart it.
And kind of give us that brief history with your family, because you have
brief.
I say brief because you have, it's not just breast cancer, ovarian cancer, and then you have it also with the men in your family as well.
Yes, men and women throughout my family. We truly would joke about that we have this family curse, because it seemed like every single person in my family would get cancer. So going as far back as I can count to great aunts and great grandparents. My grandfather died of cancer, and then we fast forward to my two aunts who got breast cancer. They were the most recent. And then my Uncle Mike, their brother, got pancreatic cancer. And it turns out all three of them had the BRCA2 mutation. And my mother had the BRCA2 mutation as well, but she ended up having a prophylactic procedure to prevent the cancer.
So following in mom's footsteps.
Exactly.
And I love what you called it, a superpower, just having that knowledge. So what was the conversation like with your doctor the minute you find this information out?
So initially I was living in Illinois at the time. And so when I found that I was BRCA2 positive, I just wanted to know what do I do? What are the next steps? And they recommended at the time breasts out at 40, ovaries out at 45. And that's kind of just what I had in my head that I would do, until I came to KU and met with Dr. Wagner, and she was wonderful about saying, this is your choice. We have really great screening. What do you want to do? And then in my gut, I just felt like, you know what, I'm 40. I still feel like now is the time, because I don't want this hanging over my head and worrying. And I don't want to do chemo and radiation. I don't want to wait for the screens to find something. And that was one thing I asked her. I said, if you find cancer in these screenings, and it's really, really small, does that mean I won't need chemo or radiation? She says, we won't know until, it doesn't matter how small or how big, like we won't know until we test it. So I was like, forget it, take them out.
So you were kind of taking that anxiety about just sitting around and waiting.
Yeah.
Dr. Wagner, what does it mean to have the BRCA2 mutation, and how does that increase someone's risk?
So this is a gene that is actually supposed to help prevent cancer. Like when something doesn't get translated right, and so a potential cancer cell, we're supposed to break that down. But when we have these mutations, it doesn't function right. So it doesn't stop those cancer cells from continuing to develop. So when we see those in patients, and there's a lot of mutations that we actually check for now, but specifically for the BRCA2 mutation, if we see this in patients, they have a higher risk than the average population of developing breast cancer, because with that gene not working quite right, it's not going to stop things like it would in you or me. And like what, I mean, Kristin's family is the like quintessential demonstration of what happens. It's not one gene, one type of cancer. it can be a host of different cancers with these gene mutations.
Thank you that was a really good way of explaining that. And Teresa, when someone finds out that they have this mutation, this BRCA mutation, what are some of the biggest fears or the questions that they have for a nurse navigator?
Well, in navigation, we've tried to provide an efficient and personalized way for the patients to have patient care. This leads to a quality appointment with our physicians and providers. Conversations early on include a thorough phone assessment to discuss their personal risk factors for breast cancer. That initial phone call allows for the patient to ask questions, discuss concerns, and to schedule an appointment with us.
Yeah, it's a very important phone call because you're often that first line of contact and somebody to kind of set those fears at ease and know you're going to get them in the right place, hence navigation. We talk with plastic and reconstruction surgeon, Dr. Rebecca Farmer, who says that this is not a simple decision and what's right for one woman may not be right for the next.
We know just from her family history and the kind of extensive, history of other cancers that have been in her other family members and her known genetic mutation that she's at an incredibly high risk of developing breast cancer, and so she won't any longer require imaging or breast screening going forward after having had a mastectomy, which I think is a lot of peace of mind for people. Like that's a big decision to make. I just tell people that I think everyone's risk tolerance is a little bit different. Not all of us are gamblers in life. Some people just want to be really as safe as they can. Some people are willing to accept a little bit more risk and are willing to kind of undergo frequent screening and just kind of keep an eye on things. And so that's a very individual decision. I don't think there's a right or wrong way. It's just the way that feels right to you. For women, a lot of our self-identity and all of that is really tied up in how our bodies look. And so there's always a bit of that psychological aspect, I think, of having to go through that mourning period and sort of accepting that your life and your body is different, and that you sort of consciously made that choice to accept that for the benefits of, hopefully not developing breast cancer in the future.
And Kristin, you said you wanted to be in control of something that you really can't control. How did you drive your decision and move forward with this surgery?
It was mainly driven by the fact that I had such strong family history, and there were so many before me who died, and my Uncle Mike, who got pancreatic cancer, he unfortunately passed away in 2021. So there was nothing he could do, and I just felt like there is something I can do. I'm going to reduce my risk by over 90% by having a mastectomy. And so to me, that was the ultimate control.
I have to ask you, because you're a fellow news reporter, we call it the Angelina Jolie factor.
Yeah.
When this happened back in the day, it feels like, I don't know, was that almost 20 years ago?
It was a while ago,
close to 15, at least 15 years ago. And I remember thinking it was so drastic, and it was like, what is she doing? No one had ever heard of this being so drastic, and it was the first time I really had ever heard of the BRCA gene. I'd never even heard of this. So,
me too. I didn't know I even had it when she had hers done.
Right. So something really good came about that, the education of it. And that's why I was wondering, because when you said your mom had one, that must have been probably beforehand?
So my mother had hers in 2020.
So recent, okay.
She was 70 years old.
Wow.
And she thought, well, I've avoided breast cancer this long, but she started having some unusual mammograms, and she thought now's the time. And she was not so sure I should get the surgery. She was kind of asking me not to do it. She's like, it's a really major surgery, and all of your mammograms have been fine. All of your scans have been fine. You might be okay. And I just thought, no, I don't think that's the way to go. I don't want to wait until it happens.
Right. And that's just a mom being concerned of her daughter going under the knife and doing surgery. And just so many unknowns. I mean, right. I can see that. Teresa, you work closely with these patients like Kristin. What are some of those early conversations like? I'm sure they get quite personal.
They do. I like to serve as a resource and a contact if they need anything. It can be very stressful. I think it's important to individualize the care, whatever the needs are of that patient at that moment in time.
Absolutely, absolutely. Dr. Wagner, what goes into determining if someone is a good candidate for prophylactic mastectomy? Is it for everyone?
It isn't necessarily for everyone. One aspect of it, I think, which I think Kristin kind of alluded to, is I feel my most important job at that first consult is for education. right? We really have two pathways now that we can and should consider when patients are found to have a mutation. Kristin chose the risk reducing route. That's mastectomy. Offers a 95% risk reduction, right? There's give and takes on both sides, because the other side is high risk screening, where we get a mammogram and an MRI every year, and we alternate them every 6 months so that they have more frequent screening of the imaging. The upside of mastectomy is you reduce your risk by 95%, right? That's an incredible reduction when you're telling her, well, you've got a 70% lifetime risk of getting breast cancer.
Yeah.
That's a lot. So the downside of mastectomy is you are essentially numb when you're done. That fine sensation, arousal, that part is lost with mastectomy, because 95% of the blood supply and the nerve supply come up through the breast tissue itself that I'm going to take away. And so that's an incredible alteration that Dr. Farmer was speaking about in her segment. On the other side is the high-risk screening, right? So the upside is you maintain your breast, your own body form. Nothing as good as what God made it. But the downside is it's a little bit like Russian roulette on whether or not you're going to get breast cancer. And then there are all of the associated treatments and side effects. As Kristin also mentioned, I can't predict what type of breast cancer you're going to get. We know that there are certain types that we tendency to see with like a BRCA2 mutation versus a BRCA1 mutation. But we have to see what the outcome is on the final pathology. And then from there, we're able to direct what is that therapy like, systemic therapy, what is the medicine that is needed.
But everything is very specialized care, and it's good to know there are options to discuss with these patients.
Yes.
Kristin, you had a mammogram in October. You were given the all clear, but you still decided to have that double mastectomy. How much time was between that mammogram and then when the surgery actually happened?
It was about 3 months, because I had the surgery January 28th.
Dr. Wagner, breast cancer was found in the pathology. Is tissue always tested even when it's removed?
It really should be. At our organization at the University of Kansas Cancer Center, I send the breast to pathology and it's assessed as if there was cancer there. So they are going to go through both, even in prophylactic mastectomies, to see is there something that imaging just hasn't been able to pick up. I mean, Kristin's fortunate was 3 millimeters. This is so small. Imaging likely isn't going to be picking that up just yet. And so that's why we do such a thorough job when it comes to the entire surgical pathologic process.
Kristin, you said you were not surprised to find out that you had the mutation.
Yes.
However, when you learned that they did find cancer, what was that moment like?
I was shocked. Truly shocked, because I just thought, I'm doing this so early. My aunts who had breast cancer were in their 50s. And my mom never got breast cancer. She was 70. And so I'm thinking, I'm just really getting ahead of the game, and they're not going to find anything. And when I got that call, I knew they found something, but even then I thought it wasn't cancer. Maybe precancer, maybe some kind of cyst or something strange, not normal, but not cancer. And when she said cancer, I'm sorry, can you say that again? Because I just was not at all thinking I would end up with it.
How often does that happen? Somebody comes in to do this proactively, and then you have to deliver that news.
Because Kristin was so diligent, and it is something that I personally make sure all of my patients before having a risk-reducing mastectomy, they are up to date on all their high-risk screening. They are up to date on their mammograms and on their MRIs. It is actually pretty rare in our personal experiences.
So what's the next step medically now for Kristin?
Fortunately, she's done. That's the great
done.
thing.
On the breast side,
yeah,
yes.
she's done. Like from the breast cancer side of things, she is very fortunate. What we found is a small 3 millimeter area of grade 1 to 2, which is a low to intermediate grade ductal carcinoma in situ. So this is not an invasive cancer, meaning it's still contained within the walls of ducts in that area. So it doesn't threaten survival. When you do mastectomy on both breasts for a ductal carcinoma in situ, there is no indication for any medicine at that point, because the medicine is really directed, when we see this in lumpectomy patients, to reduce their risk of getting another new cancer in the future, okay? Versus when you have an invasive cancer, it's to keep it from spreading to other places in the body. And that is the inherent difference, is she's already had a 95% reduction of getting new cancers. That's what the mastectomy offered. and therefore she just doesn't have a need for any medicine, which is really fortunate.
So for women who choose surveillance instead of the route that Kristin took, how does that differ? You touched on it a bit. Just explain how that differs as far as long-term care.
Right. So those patients are going to be seen in our high-risk program and see either one of the physicians or APPs in that system. And every 6 months, they're going to be getting imaging. And we alternate between mammograms and MRIs because they actually identify different things. The thing I get quite frequently, and I'm sure everybody here can understand, is women don't exactly love to get their mammograms. They don't like the compression, but it is worth the reward of finding what mammograms can find, because even if you have dense breast tissue, mammograms can find things, and DCIS happens to be one of them. Low to intermediate grade ductal carcinoma in situ often present as calcifications, and despite having dense breast tissue, we can see that on a mammogram. Those are not really fast-moving cells, and that is what actually can be missed on an MRI. And that's why we need these two together.
So besides this mutation, what else would send someone to the high-risk breast clinic? Why else might they utilize those services?
We actually have a broad spectrum of patients. Obviously, if patients have mutations, as long as they are wanting to continue to maintain their own breast, we want them in that high-risk program and high-risk screening. But we also have patients that have high-risk lesions, which means we've done a biopsy, and under the microscope we see some cells that are a little bit different than the normal cells that we would see in the breast tissue. And those, through many research studies, have shown us they have a higher risk than the average population. Not high enough risk that they need to have the mastectomy to reduce their risk, but enough that we should follow them a little bit differently. And again, talk about those medicines that might be able to reduce their risk of getting a breast cancer.
Well, be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Kristin, you mentioned your surgery was the end of January. How are you feeling now, today?
Yeah, I feel great today. You have the loss of sensation in your breast, and that really hasn't bothered me too much. I have sensation in my chest in between, and that's, I have found, like, very helpful to kind of recenter myself. Like, oh, I can feel that. Okay, this is a helpful thing to have. I feel really good about the moving forward and the prognosis. I did have a complication of pain, but that has also subsided now, and I'm doing great.
And they wanted to rule out that it was a blood clot or something serious, right?
Correct. Yeah, I did a CT scan because it was about a month of pain, and it started in my side and radiated in my back, and I couldn't do the exercises I needed to do post-mastectomy. And I'm thinking, this isn't normal. And we had the drains pulled out, and that was the thought, is the drains were compressing a nerve. And when the pain still continued after those drains were pulled, that's when it was, okay, we need to investigate this further. Something else is wrong. And it ended up being a nerve issue from removing the tissues of my surgery. And there's nerves everywhere. It can happen. It happened to me, but doing fine now.
Dr. Wagner, what does recovery timelines usually look like for a patient like Kristin?
I encourage them to take 4 to 6 weeks off, minimum. She did have that side effect of a neuropathic pain, and fortunately we were able to get her through our pain management system and get that resolved. But in general, there's not tons of pain because everything is numb by taking away so much of those nerves. But we're doing a lot of surgery, and it takes your body energy to heal. So you can be very fatigued, which I'm sure you also experienced after surgery. And we underestimate that. So we're always taught, push through the pain, push through the fatigue in life, right? But this is a time I tell patients, no, you need to listen to your body. It's giving you signals that I need rest. It is okay to sleep. We need to sleep to heal. And, affording yourself that grace is very important to have the best outcome.
So this has not just been a physical journey. We've talked about that here this morning. It's also been quite emotional on just making this decision in your life. How has the support at home been for you?
Support's been great. My parents stayed with me for a month. And I remember thinking, I don't need you that long. Like, Mom, Dad, I love you, but it's fine. And then I remember after like 2 weeks, like, no, I definitely need you that long. Because you just can't, I couldn't do almost anything for myself. Even reaching up in the cabinet couldn't do it. I needed help. And so having that support was crucial. And then obviously my husband as well, having him be there and they had to do a lot of work that may not be pleasant. You know, you got to clean out the drains, and there's fluid in there and tissue. And I get kind of queasy with medical stuff. So I was like, I don't know if I could do this for any of you all. And I'm like, I don't want to see it. And they did it for me. They were just truly amazing.
Fantastic. And Dr. Wagner, what does life and follow-up look like for Kristin now that she has had this done?
So there's no more imaging once we've done a mastectomy, because there's no breast tissue for us to get pictures of. But physical exam becomes very important, and I've highlighted that many a times that you and I have talked about. Even before, when you have your own breasts, and just the average woman walking around, know what is normal, and if it is not, have somebody check it out and be your own advocate. It is the same thing, but probably to a higher level, because we're not getting any type of imaging. You have to know the new you, and that's the next process, is what this feels like after mastectomy, what it feels like to have an implant in, or if you use autologous and use your own body tissue, what does that feel like? And so over the course of the reconstruction, we want to be routinely examining patients. And then once all of that is done, okay, now we know what the new you feels like. And then we just rely on physical exam.
Kristin, you made a very personal and proactive decision for yourself. What would you say to other women who may be on the fence about testing or surgery?
Testing, oh my gosh, you get it. I understand people who don't necessarily want to do the surgery. Maybe they got young kids and life is just really hectic and they need to be physically present and have the ability to pick up their kids. I understand if they want to do the screening, but do not put off getting that test for the genetic mutation, because again, you have it regardless. Whether you know it or not, wouldn't you rather know? Because then you get to make the decisions moving forward of what you do. And your reaction to something doesn't change the reality of something. It will always be the reality. So I would rather, look at this in the positive light, that what a glimpse into the future that I have that most Americans do not have. And I get to decide what to do about it.
Dr. Wagner, we heard Dr. Farmer mention there's no right or wrong decision for a woman. How do you help each patient who comes into your clinic make the right decision for her?
One is giving them time, educating, spending a lot of time in that first, and equal balance of what their options are. I have been teased by some patients. They're like, "Are you a surgeon? Because you're giving me an option of not operating." I'm like, yes, that's a sign of a good surgeon, right? Is knowing when and when not to operate. But it is truly that balance of education. What are all of your options? And I feel very passionate about getting to know my patients so that I hear them. What are your priorities? What do you have going on now? What are your long-term goals? And then how do we together come up with the right answer on how we're going to move forward?
Teresa, for anyone watching who might have a family history of breast cancer or any type of cancer, what are the first steps they should take?
They should definitely talk to their healthcare provider about their family history and then discuss with them what next steps might be. We accept referrals from the providers and also self-referrals. The number to call would be the 913-588-3671. That's for entry into a referral at KU.
Thank you for that. Kristin, something very cool that you're doing, no surprise, you're documenting
Yes.
your entire journey. Well, you have to, because you're so used to documenting everyone else, and now it's your turn. Why was it so important for you to share this publicly?
I think two reasons. One, like you mentioned, I have been with people on the worst day of their lives asking them to share their stories. So why should I be any different, where I'm going through something that can actually help people too? I didn't know people outside of my family who had a BRCA2 mutation, who had a prophylactic mastectomy. It seemed very just insulary for our family. And I'm just like, I know that's not true. I know there are people all over the world who have this. And I had, aside from Angelina Jolie's op-ed article 20 some years ago, I really haven't heard much about it. And I thought, let me at least be something that people can look to, as let me see what this journey was like, and maybe that helps me make a decision on my journey. Maybe it helps me make a decision on speaking to a doctor. getting genetic tested just does something, because if we can prevent cancer from happening, if I can prevent that with a story, I would do one every single day.
Nice job. Thanks for sharing, for sure. We want to get to some questions from our viewers this morning. First one's from Angie, asking, if I have a family history of breast cancer, when should I get genetic testing?
That's a great question. We normally don't do testing before the age of 25, just because there is a lot that, I know Kristin has shared the emotional, the psychological impact of that, and we're still growing and maturing a lot at that age. But anytime after that is a great time. We also would strongly encourage you to talk to your family members, the people who have had the cancer. Those are actually the best people for us to be testing, because if they've had the cancer, that's the most probable patient to have the mutation. And then if they're negative, well, then they have nothing to pass on to that next generation. Now, sometimes either they've passed away from cancer, that's just not the family relationship they have, and that's fine. And then we have opportunities for patients through our high-risk program, through their primary care doctor, a lot of different avenues to get into a genetic counselor to have that testing done.
Becca wants to know if this is typically covered by insurance when it's a preventative surgery.
Great question. It should be, yes. So if you have a mutation, the mastectomy should be covered. And that is in part for us on my side is documenting correctly so the insurance companies understand, why am I doing this? Well, because she has a 70% lifetime risk of having a breast cancer. Well, that's just unacceptable. So when we have other opportunities, whether it be covering the mastectomy or covering the MRIs, that's the other thing it can help cover by risk stratifying and documenting that.
What are the biggest risks or side effects after this type of surgery? Lisa wants to know.
What are the most common
risks or side effects of a surgery like this?
So with mastectomy, the two most common are bleeding and infection. I mean, that's obviously with a lot of different surgeries. In particular, when you're getting reconstruction, there's going to be a slightly higher risk than if you elect to go flat. And that's just because we're putting a foreign device in when we do implants. And so there's going to be a little bit higher risk of infection. Now, I say that those are our most commons, and then the nerve pain that we've also briefly touched on, but the risks of those are low, less than 5 to 10%.
Such a great conversation. Teresa, I want to start with you on just what do you want the big takeaway from this story to be?
To feel comfortable talking to your provider. If there's any family history, open up the topic and they'll help guide you.
Great. Dr. Wagner, what's the big takeaway from Kristin's story? What do you want people to know?
Well, be your own advocate. I mean, I'm sure you're exhausted of me saying that, but like I just can't say that enough on this program, because you know we are more educated as consumers, but also as healthcare providers than we have ever been in history, and so it's a partnership between us. But I can only help you as much as you tell me you need help. And so if you are not advocating for yourself, and if your gut is saying something just isn't right, pursue a different avenue.
Ask questions. Mm-hmm. Kristin, I'm going to let you wrap us up on this Friday.
Oh boy.
What's the big takeaway from this journey? You want us to know?
I mean, if anything, I am a lesson of why this surgery is important. I did not think I had breast cancer. I truly thought I am going to prevent this from ever happening. And I did, and I didn't know it, and it was too small for scans to pick up. And it was shocking. But for anybody on the fence, I mean, I'm so grateful I did this surgery, because I can't imagine that continuing to grow in my body and become a bigger problem than it ended up being. And now the next step for me is a hysterectomy, and because I want to prevent ovarian cancer. And I'm going in that with a little bit of trepidation, like I really hope I don't have ovarian cancer because I already had breast cancer. But again, it's using the knowledge that I have. I'm doing it earlier than I expected because I wasn't going to do that till 45. Now we're up in the timeline because as much as I can to be in control, this is what I can do. And for anybody else watching there who thinks they may have the gene, knows they have the gene, just take that to heart, that you can learn more. Knowledge is never a bad thing. It can be really scary, but it's never a bad thing to have.
Kristin, thank you so much. We're just glad you're doing well Thank you for sharing. Thanks to all of our guests for being here with us today. Thanks to our viewers for joining us, and we'll see you here on Monday.
Oh, it was terrifying. Life-changing in the worst possible way.
Coming up on Monday, 2 young moms, both nurses, both facing colon cancer. The warning signs they almost missed and why doctors say this disease is showing up more and more in younger patients.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.